start. So we're going to try and stay on time. We have 4 speakers, and they're each allotted 15 minutes total, of which we might expect about 10 minutes of actual presentation and then the remaining 5 minutes for Q&A from the audience, so that all of you are here as audience members. And I'd like to introduce the first speaker, who is Josh Klaus, and he's going to speak on validation and application of E. coli contamination risk sensor in the U.S. surface water. And he is from where?
We'll introduce ourselves too.
Okay, all right. Well, I'll let you get on with it. The floor is yours.
Thanks for the introduction. My name is Josh Klaus, and I'm joined by Whitney today to talk to you all about our work on a real-time E. coli monitoring device. And we're from the University of Colorado Boulder with the Mortensen Center in Global Engineering.
Awesome. So to get into a little bit today about our motive, why we're here, we're focused on microbial water quality monitoring. And it's no surprise to most of us here that surface waters have been becoming increasingly polluted as a result of aging infrastructure, combined sewer overflows, overloading, and discarding right into surface waters, as well as runoff and other extreme events that have been exacerbated by climate change. Furthermore, monitoring for microbial water quality is incredibly important in high-income countries in order to comply with regulations, as well as protect recreational and public health, as well as identify locations that are particularly vulnerable to contamination.
Okay, so in order to monitor for fecal contamination in water, we need some kind of quick, effective, and accurate way to monitor water sources. There are several existing technologies that are in use today, the most common of which are membrane filtration or call alert testing. And in general, these sort of tests indicate the presence of fecal indicator organisms, such as E. coli, which is what we have focused on. The existing technology typically involves taking a water sample from the source of interest, spreading the water sample across some sort of nutrient plate, and then incubating the plate at high temperature for 24 hours, which reveals how many colonies we're able to grow and gives you a direct enumeration. Probably a lot of you are familiar with this sort of work and know that there are some inherent limitations in the system. It often requires expensive lab equipment and specific training for lab protocols. It requires time-intensive fieldwork. You actually have to physically visit the sites you're sampling, and it is time-limited with an inherent 24-hour lag. To put it simply, if somebody poops in the pool, it's kind of a shame to find out 24 hours later.
So, as this is a WaSH conference and a lot of our work is also focused in low and middle income countries, we do want to note that there have been many alternative approaches to this for improving field monitoring. However, it still exists with inherent lag and really limits the spatial and temporal density of water quality data that we can collect. As such, tryptophan-like fluorescence, or TLF, has become an ideal research parameter focused for microbial detection. So TLF is a fluorescence wavelength that has been known to be highly correlated to E. coli in drinking water sources or any surface water. And TLF has become an ideal potential indicator for fecal contamination or microbial activity because it is both reagentless and doesn't require consumables in your monitoring. As such, it can be monitored with a simple fluorimeter, allowing for real-time detection of fluorescence. This has been proposed to be used as an early warning indicator or measurement of potential risk of waters. However, TLF itself is not immune to its own challenges. Environmental factors have been known to influence and quench TLF signals, such as temperature, turbidity, and other fluorescing microorganisms. Beyond this, there has not been any literature identifying a universal correlation between fluorescence intensity and direct enumerated E. coli, making it incredibly challenging to apply this technique without any other potential indicators.
Okay, so Whitney and I have had the privilege of working on the validation of a TLF sensor. Reveal the sensor. This has been a work in progress for many years before us, so we are just in charge of the validation of this most recent iteration. As you can see, it's very compact, and we've designed it for continuous in situ remote use, so you can drop it in any kind of water source of interest And it takes fluorescent measurements and transmits the data via cell networks. So it works perfectly remotely and with minimal maintenance. The sensor also includes a machine learning algorithm, so it takes fluorescent measurements and then includes a host of environmental factors into a machine learning model, such as pH or water temperature, as well as maintenance activities like cleaning the sensor, which provide a more accurate measurement and can account for long-term issues like biofilm accumulation or mineral scaling on the sensor. So to go about building this regression, we have to collect a lot of water samples alongside the sensor voltage. To do this, we've worked with a host of partners across both the US and a few international deployments. We tried to get as wide a range of data to encompass different water quality parameters in the hopes that these can be more universally applicable to different water sources. The procedure at these deployments is to install them in whatever water system we're interested in where we know there's contamination, and then periodic point source water samples are taken and enumerated using traditional lab methods. We've looked at call alert and membrane filtration.
So as Josh mentioned, this validation is occurring concurrently while we're investigating some of the ideal potential applications for a real-time monitoring system. Several of these pilots have been across the US and also in other high-income contexts such as France. So the first of these is right in our backyard at home at the University of Colorado along Boulder Creek. We are partnered with the city of Boulder to have installed 4 sensors along the highly recreated Boulder Creek, which is popular amongst students and other people living in Boulder as a recreating area during the summer. Interestingly enough, the city of Boulder is also regulated under a total maximum daily load, or TMDL, for E. coli, making it an ideal location to monitor at more frequent intervals. So we have been able to support recreational safety monitoring as well as improve their data collection in comparison with the samples that the city of Boulder is taking. Additionally, we partner with the Sorbonne University and other universities in Paris to install 3 sensors along the Seine and 1 sensor along the Marne in Paris, France, in order to monitor their bathing areas for swimming and increase the high-frequency data collected along this area. As we know, France has been highly publicized for potential illnesses and risk of public health associated with swimming in polluted rivers. Finally, we're also partnered with Current and H2 Now, which are innovation engines located in Chicago, Illinois. So we have installed a sensor along the Calumet River as part of their monitoring for swimmable cities initiatives. And it's important to note that along with our other deployments, which I have listed here, we are always partnered with an organization, and these data are collected as a pilot project, never just strictly informing or developing data that has not been thoroughly validated. So a couple of other focuses that we intend to target with these various applications include the safety of field teams during storm events to reduce challenges associated with travel during high-risk events, as well as highly trafficked areas that are ideal for preservation. In our final application in Manchester Bay with Blues Wireless, we have investigated potential impacts of a saline environment where the sensor is installed as well.
Okay, so while this is very much a work in progress, we do have some pretty promising preliminary results to share today. This chart shows all of the enumerated lab samples that we've collected across all the deployments, as well as the output of our continuous machine learning model. So this outputs specific down to the 1 colony forming unit per 100 milliliter units. And so far we see about 20% log scale error across the measurements. Ideally, we would follow that red line, which shows a perfect linear regression, but of course there is quite a bit of variation in the data. We strongly suspect so far that this is mainly responsible from inherent variation between different sensors. Sometimes 2 sensors reading the same water just output slightly different numbers. And we've also had a bit of uncertainty in our enumeration methods. So we're using collar and membrane filtration, and sometimes on the same water sample we'll see up to an order of magnitude difference in E. coli concentrations, which makes it difficult to establish a ground truth to build the regression off of. We've had slightly better results in another model, which is a global categorical prediction. So this is how the sensor attempts to categorize a water sample as either low, medium, or high risk. So these 3 categories are 0 to 10, 10 to 300, or greater than 300 colony-forming units per 100 milliliters of water. The darkness of these squares indicates how much of the data falls into the correctly predicted category. And again, here we're seeing about 20% error across all the predictions. And one significant limitation so far has been our low success rate in the lowest risk category, the 0 to 10, which is simply because we haven't collected much data that falls within that category. Most of the places we're sampling are just heavily contaminated.
So having the privilege to work on these pilots over the past several months and collect a lot of data, we have seen some significantly promising results, as Josh just shared, but we are still facing some challenges that have been illuminated by these deployments. That includes some user feature areas that we are continuing to try and improve on, including the charging and opening of the sensor itself, as well as some of the challenging ambiguity of results. We're starting to sort of reach the limit of accuracy on the first version of the sensor based on its hardware. Finally, as Josh mentioned, we're experiencing a lot of challenges with developing the ground truth data set on which to train the model, leading to some ambiguity and inaccuracies there. These kind of transition, of course, into our final steps, where we will be validating the newest iteration of the model that we will likely be doing as soon as we return to Colorado following this conference, and deploying the newest version of the sensor and validating that at both the lab scales and the field scales with some of our future deployments that we have listed. Additionally, we are investigating other fluorescence-based parameters, including chlorophyll A and fluorescent dissolved organic matter, as a suite of sensors that will continue to contribute to overall predictions. And with that, we'll close out saying thank you very much, and we'll take any questions.
Come on, some of you must have questions.
All right, awkward moment.
Here's one.
I was just wondering, do you have plans for validating against pathogenic organisms at some point? Like E. coli has come with a mixed bag for and that's currently your validation structure. Are you planning at some point doing validation against the actual types of pathogens that you're after?
That's a great question. You want me to take that, or you?
I can start. So we've chosen E. coli because it's simply the most widely recognized indicator organism for fecal contamination. So we know it's not maybe directly responsible for all the illnesses born in fecally contaminated water, but it's kind of the best option as a risk indicator, which this type of sensing, it's only a proxy for E. coli at that. So it's not something we can directly detect any actual pathogen of interest. So it's in itself limited in that way. So yeah,
That's a proxy for a proxy.
Yeah, exactly. So at some stage, it can only be a risk sensor.
I also have a similar question about specificity. In principle, you can discriminate E. coli from other species. Also, the other question is, do you have any range you can detect? For culture-based method, you have to do the serial dilution. The sensor has to do it.
Great, so I'll try and catch kind of both of those first parts. Could you remind me of the first part that you said?
The specificity, like E. coli versus other.
Definitely. Yeah, so we are only comparing to E. coli because that's what we're developing as the ground truth. So we don't have data on the other things that the sensor might be picking up on, which is fluorescence-based, which is what presents as somewhat of a challenge, as not ideally, I guess you could say, directly enumerating for anything. And so that's why we have sort of categorical ideas of risk that are associated with something rather than exact identification of species, as we are aware that there are many things that fluoresce in the same wavelength as TLF that include all of those compounds. And then the second part was detection limit or range. Yeah, so let me go back actually. In our continuous model, again, one of the limitations that we've experienced thus far is that we do have a pretty narrow range because we typically do environmental sampling. So at the lower end, where you see anything less than 10 CFUs per 100 mil is a pretty difficult challenge, not necessarily only for the sensor to detect, but also based on our ground truth methods, we're seeing levels of error up to 30%, which is inherent in those methods, which makes it challenging to identify orders of magnitude at such a low range. But we do see unfortunately, the Seine is pretty contaminated. And so some of those higher data points that we have, up to tens of thousands of CFUs per 100 mil, are landing so relatively accurate with the rest of the model.
Okay, well, thank you very much. I think we're going to have to move on to the next presentation. Okay, next presentation is by Cameron Smith, is that correct?
Yes.
Assessing septic system performances and socioeconomic impacts. Waterborne in Maryland. University of Maryland School of Public Health.
Hi everyone, my name is Cameron Smith. I'm a PhD student at the University of Maryland School of Public Health, Department of Global, Environmental, and Occupational Health. And today I'll be presenting on my research assessing septic systems, flooding, season, and socioeconomic impacts on food and waterborne illnesses in Maryland, which is part of a project led by Dr. Allison Riley at the University of Maryland Department of Civil and Environmental Engineering. And just a quick note that this research and data is not yet published. So just a brief overview of what I'll be talking about today during presentation, starting with an overview of systems and wells. So in Maryland, there are about 420,000 homes that rely on septic systems, and about 52,000 of these are located within 1,000 feet of tidally influenced waters, or what we call the critical area. There are also about 350,000 homes that rely on private wells, which are not regulated by the Safe Drinking Water Act, so it's up to the individual homeowner to ensure that they are following the recommendation of annual testing. If septic systems are not functioning properly or if they are not well maintained, it's possible that exposure to pathogens can occur. This could be through direct contact, but it could also be due to getting into the well. So the fecal matter could get into the well, which could carry those pathogens. Recent work that I did, which I included a graph here on the PowerPoint, it's not yet published, but I found after sampling 79 wells through all 7 regions of Maryland that there was 43% of the samples were positive for total coliforms and 10% were positive for E. coli. So this is showing, while we don't necessarily know if they were on septic systems, we do know that it's showing there's a risk of fecal contamination in the drinking water. And again, there could be different sources of contamination, but we really want to see is septic systems one of those sources. So the Foodborne Diseases Active Surveillance Network, or FoodNet for short, does surveillance on 8 pathogens in 10 states, including Maryland. And I just wanted to make a quick note that as of July 1st, 2025, it's only required to do surveillance for 2 pathogens. It collects data on laboratory-confirmed cases, and it collects different environmental exposures, such as swimming in treated or untreated water, food consumed, recent travel, septic system usage, and reliance on private wells as the primary drinking water source. It also collects symptoms, demographics, and the onset symptom date. So the goal of my project is to analyze Maryland FoodNet data from 2010 to 2022 for 5 pathogens. But for this presentation, I will be focusing mainly on Salmonella and Campylobacter. And I want to identify the associations between septic systems, flood risk, socioeconomic factors, season, and food and waterborne pathogens. So just briefly going over the methods. So I obtained FoodNet data from the Maryland Department of Health. I got percent of parcels on septic systems and floodplains from our collaborators at the Resources for the Future in Washington, D.C. And then I got my socioeconomic data from the United States Census Bureau. I calculated incidence rates per 100,000 population, conducted chi-square tests, and then various models of univariate and multi-level negative binomial with the manual backward selection. So briefly just going over what we're seeing for the pathogen incidence rate by year. If you look at the light blue, which is Campylobacter, and the dark green, which is Salmonella, we can see these have the highest incidence rate from 2010 to 2022. Even with any fluctuations in reporting, we're still seeing they're leading the cause of infection. If we break it down and look at it by season, we can see that all of the pathogens have highest average incidence rate during the summer months, and all of the pathogens, except for Listeria, have the highest average incidence rate in the winter months. When I did a chi-square test, I found that there was a significant association between season and the presence of Salmonella, Campylobacter, Shiga toxin-producing E. coli, and Cyclospora. Now getting into the negative binomial models that I focused on, I first started with the univariate negative binomial model, and I did this for each of the predictors of interest, so I ran a separate model for each of those. So I found that there were 4 significant positive associations, and this was percent of parcels on septic systems, percent parcels in floodplains, percent residents 65 years and older, and percent white residents. So essentially what this is showing is that in zip codes with a higher percent of these 4 predictors, there's an increased risk of Salmonella incidents. And I'm demonstrating the incident rate ratios on the screen with these. I then ran a multivariate negative binomial model using those significant factors from the univariate models, and I did a manual backward selection for that. I found that across zip codes, higher Salmonella incidence was associated with a higher percent of parcels on septic systems and a higher percent of parcels in floodplains. So an increase in septic systems, an increase in floodplain was showing an association or a significant increase in Salmonella incidence. The 2 figures, or the maps, are showing the Salmonella average incidence rate, which we can see in the blue fill in the zip codes, that it's highest in the Eastern Shore, and specifically highest in Somerset County, which I circled. The map on the left is showing the percent of parcels on septic systems, which we can see is pretty well scattered throughout the state. And then the map on the right, the red dots, is the percent of parcels in floodplains. And we can see this is very much heavily located around the Eastern Shore, specifically around the Chesapeake Bay region, but it's highest in the Somerset County. I then ran a multivariate negative binomial model, but this time focused on the interactions, because I wanted to see if there was interactions between percent of parcels on septic systems and socioeconomic predictors. So again, I'm showing the incident rate ratios for the 2 predictors that have a significant positive interaction. So this is percent of parcels on septic systems and percent Black and African American residents, and the other is percent parcels on septic systems and percent of Hispanic and Latino residents. So this is showing that the effect of percent of parcels on septic systems on Salmonella incidence depends on the percent of Black and African American residents or percent of Hispanic and Latino residents. So a zip code with a higher percent of septic systems and a higher percent of Black and African American residents or Hispanic and Latino residents has an increased risk of Salmonella. And this is really interesting because if we think back to the univariate models, we were actually seeing different effects of those 2 race predictors. For percent Black and African American, it was a significant negative association, and for percent Hispanic and Latino residents, it wasn't significant. So this is pretty interesting to see how we're seeing a different effect when we look at it by itself versus looking at the interaction. I then ran the same models again, but this time I'm focusing on Campylobacter incidence. So I ran the univariate negative binomial models for each of the predictors of interest. And again, I found that the same 4 predictors were significant. So this is percent of parcels on septic systems, percent parcels in floodplains, percent residents 65 years and older, and percent white residents. So just like for the first time, this is showing that in zip codes with an increased percentage of these 4 predictors, there's an increased risk of Campylobacter or Campylobacter incidence. I then ran a multivariate negative binomial model using those significant factors. And I just wanted to make a quick note that for this one, to eliminate any collinearity, I ran a different multivariate negative binomial model with each of the 3 race predictors on their own. So for this one, just to save time, I'm showing the results with using the race predictor of Hispanic and Latino residents. So when I ran this model, I was finding that across zip codes, higher Campylobacter incidence is associated with a higher percent of parcels on septic systems and a higher percent of higher percent of residents over 65 years. There was also a lower incidence associated with a higher percent of Hispanic and Latino residents. What's interesting is we actually are seeing, unlike Salmonella, that floodplain did not remain significant in the multivariate negative binomial. The maps are showing the same thing in terms of percent of parcels on septic and percent of parcels in floodplain, but this time we're looking at Campylobacter average incidence rate, which we can see is actually highest in the western region and specifically in Allegheny County. Then I ran my multivariate negative binomial model, again looking for those interactions, and I was finding that the interactions between percent of parcels on septic and socioeconomic predictors, I found that there were two significant negative associations. So this is percent of parcels on septic systems and percent residents 65 years and older, and the other is percent parcels on septic systems and percent white residents. So essentially, again, this is showing that the percent of parcels of septic systems on Campylobacter incidence depends on percent of residents 65 years and older and percent white residents. If we focus mainly on that second data point of the percent white residents, this is essentially showing that there is a higher risk for non-white residents who are also on septic systems. So overall, we know that Salmonella and Campylobacter are major pathogens of concern in the United States. We know that they're the leading cause of food and waterborne illness and hospitalization. This research emphasizes the association of septic systems, floodplain season, and socioeconomic factors with food and waterborne pathogens in Maryland. And it's also showing why it's important not to just lump food and waterborne pathogens in one category, because they can have different causes and different environmental exposures. So we really want to investigate them separately. And then lastly, again, this could impact the about 420,000 Maryland homes on septic systems and the 52,000 that are within critical areas. And then I just wanted to thank you for joining my presentation today. I included the email information for myself as well as my advisor, Dr. Rachel Rosenberg-Goldstein. And then the left is a QR code for the lab that I'm a part of, which is the Water Quality Outreach and Wellness Lab, or WOW Lab for short. And then the right is the project, the Septic to Sewer project that this research was done with. So thank you, and I'm happy to take any questions.
I can break the ice again. Have you or will you look at interactions between parcels with septic and floodplains and or season? It seemed like you kind of looked at them one at a time, but.
Yes, I have like a lot of goals with this project of things that I want to look at. I'm very interested in a lot, so I still have more work that I'd like to look into. But yes, I'm planning on looking at those interactions between season and between the percent floodplain, and also bring in other factors as well, because there's a lot of different environmental exposures on that food net survey that they give the individuals with the lab confirmed case. So taking like responses from that, like looking at different elements to just kind of connect it. But yes, definitely gonna look at those too.
Yeah. Sorry if I missed it, but did you have any income data?
We did include that in the socioeconomic, yes, I did. So when I ran the models and included socioeconomic data, like my univariate and multivariate, I did include different income data, but it just was not significant, so I didn't include it in this.
And it was at, what, census block level or
All
census tract
the
level?
data was at the zip code level, so.
Okay.
Yeah.
Oh, all the data was at the zip code level?
Yeah.
Okay. And did you do the whole, your data set the whole state of Maryland?
So in my models, it was recommended to me by the biostatistician I worked with to do it for the whole, like all the zip codes in Maryland, even for the zip codes that didn't have a reported case. So that way we can still look for the entire state. But yes, not all of the zip codes had a reported case. And it also is just showing that the net data is just giving us a glimpse of the food and waterborne illness. We're not necessarily getting all of the cases. It just depends on reporting and going and getting that confirmation. Yes.
Was the age of the systems taken into consideration?
No, not for this study, but I would love to look into that further if possible, if we have that data. I don't know if FoodNet collects that data, but even for other studies looking at the age of the system, because I know in my other work that like age of wells and maintenance of wells and even like septic systems, same thing, that really plays a big part as well. Yes.
I'm familiar with the region. I'm just wondering, there's so many implications here for the receiving waters in Chesapeake Bay. There's a lot of water quality work going on. Do you work with those organizations or?
For this project, I worked a lot with individuals in Resources for the Future, SIRCAP, and University of Maryland Extension. Those were the main ones. But I know that my people I've collaborated with and my advisor, they have those connections that they've been able to help us with that.
And sorry, I couldn't quite tell from the maps, but is there a geographic clustering in terms of which zip codes have septic systems versus not?
I do have a list of the individuals or the zip codes that have the highest percent, but I can't think of it on the top of my head, but I could definitely get back to you on that. But my next step that I'd like to do is look at more of this like spatial analysis and do like a cluster analysis is my goal, and like a hotspot analysis. I have a percent of which areas have the highest percent of parcels on the septic system, just don't have that right with me right now. Sorry about that.
Okay, well, thank you very much. Okay, next speaker. Is, are you Pearl or Francis? Pearl, okay. Pearl and Ante-Testard, correct? Okay. Is going to speak to us about the effect of WaSH interventions on Giardia infection in Bangladesh, heterogeneity by exposure to seasonal monsoons. She's from the Department of Ophthalmology, University of California.
So good afternoon, everyone. Again, I'm Pearl Ante-Testard, postdoc at UCSF's Proctor Foundation. So thanks everyone for being here. So today I'll be presenting our work on seasonally varying effects of improved WaSH on Giardia infection in Bangladesh. So this study has evolved since we submitted the abstract, so there's a change in the title. So to give a context, children in rural Bangladesh face high rates of diarrhea and frequent rainfall, especially during the annual monsoon season. Giardia is one of the most common enteric parasites during the first years of life in low-resource settings, and also one of the most neglected, unfortunately. It can cause both acute diarrhea and prolonged infection and asymptomatic carriage, which can impact child growth and development. Transmission occurs through contaminated water, food, surfaces, or person-to-person contact, all of which can be influenced by environmental conditions such as precipitation, and which may vary across settings. So this picture that you see is a picture showing severe flooding in the northeast of Bangladesh, which is a reminder how dynamic the local conditions can be. So the WaSH Benefits Bangladesh trial was conducted in 2012 to 2016 to evaluate the early life impacts of WaSH and nutrition interventions in 4 rural districts in Bangladesh. Over 5,500 pregnant women were enrolled from 2012 to 2013, and 720 clusters were randomized to interventions including individual water treatment, sanitation, hand washing, combined WaSH, and combined WaSH plus nutrition, and also a double-size control arm. So each birth cohort household received the full WaSH and nutrition interventions, and newborns were followed for about 2 years from 2014 to 2016. So it was found that WaSH is a key strategy in reducing child diarrhea morbidity and mortality. In addition, previous analysis also showed that WaSH interventions had greater reductions in all-cause diarrhea, especially during the monsoon season. However, whether WaSH can mitigate the seasonal variation in Giardia infection remains unclear. Thus, our aim was to assess the seasonal variation in the effects of improved WaSH on Giardia infection in rural Bangladesh. So we hypothesized that improved WaSH reduces Giardia infection with stronger effects during the periods of heightened environmental exposure when transmission risk is likely to be elevated. So in this study, we conducted a secondary analysis of the WaSH Benefits Bangladesh trial, and we used a 2x2 factorial design of the WaSH and nutrition interventions, excluding all the single interventions except for nutrition. So this factorial design allowed us to estimate the effect of WaSH and nutrition at the margins, where we estimated the effect of WaSH and nutrition independently while gaining statistical power. Since no significant interaction was observed between WaSH and nutrition, we focused on the effects of improved WaSH, which is comparing groups that received any form of WaSH versus groups that received no WaSH. And in addition, nutrition was found to have no effect on Giardia in a previous analysis. So we focused only on WaSH on this study. So in total, we had 2,273 children in our study. So this figure illustrates each child from their birth on the left to the time of measurement up until the right part of the figure. So our outcome of interest was the PCR positive Giardia infection measured at end line in 2015 to 2016 through stool samples. So for our effect modifier, we had a binary season, dry versus monsoon, at the time of measurement here, as we see on the graph. We define monsoon season as the elevated precipitation, which was based on a previous study, and dry season as the other months. We then estimated the effect of improved WaSH on Giardia conditional on season at the time of measurement using linear, generalized linear models. So this figure shows the Giardia prevalence between WaSH and no WaSH during the dry and monsoon seasons. We observed higher Giardia prevalence for both WaSH, as depicted by the blue error bars, and no WaSH groups, the gray error bar, during the dry season, which we see here as the period of elevated transmission risk. This figure on the right shows the prevalence difference between the WaSH and no WaSH groups. So 0 means there's no difference in Giardia prevalence between WaSH and no WaSH, and values below 0 indicate reduction in Giardia due to the WaSH interventions. So when stratified by season, we see that improved WaSH reduced Giardia infection consistently across both dry and monsoon seasons, with the absolute reduction slightly larger in the dry season when baseline prevalence was higher. So now we saw that the period of elevated Giardia risk was in the dry season at the time of measurement. So our next approach was to calculate each child's cumulative months of dry season exposure from the time of their birth to the time of measurement from 2012 to 2016. So since Giardia can persist asymptomatically, and therefore it's difficult to identify when infection actually began, this framework can capture children's cumulative exposure to climate conditions from birth to the time of measurement, which can provide a simplified representation of both the timing and duration in environmental conditions that can influence infection risk. And in this high prevalence context, the cumulative exposure to the dry season may also act as a proxy to prior Giardia infection history. So since births occurred at different times, from 2012 to 2014, each child's cumulative exposure to dry and monsoon seasons from the time they were born to the time the outcome was measured varied, but with the exception of twins. So we estimated the effect of WaSH on Giardia conditional on the cumulative dry season period using generalized additive models. So first here we show that the distribution of the cumulative dry months that the children experienced were balanced between WaSH and no WaSH groups. So this plot shows the prevalence of Giardia between WaSH and no WaSH along the range of cumulative dry months. Among children without improved WaSH, the gray spline, Giardia prevalence increased with longer exposure to dry periods. In contrast, among children with improved WaSH, the blue spline, the prevalence was consistently lower and the gap widened with greater dry season exposure. And on the figure on the right, we see the prevalence difference between wash and no wash along the range of the cumulative months of dry season. Again, 0 means there's no difference in Giardia prevalence between the two groups, and values below 0 indicate protective effect of wash. So we observed that improved wash showed larger absolute reductions in Giardia among children with greater cumulative dry exposure. So to summarize, we found that first, Giardia risk varied seasonally, peaking in the dry season. Second, improved wash consistently reduced Giardia infection across seasons with a slightly higher absolute reduction of about 6% during the dry season. Third, children with greater cumulative dry season exposure experienced greater reductions due to wash. And fourth, children experience dry and monsoon seasons differently depending on the timing of their birth, which led to varying exposures to seasonal conditions. And lastly, our findings highlight that wash enhances resilience to seasonally varying infection risk. So with that, I'd like to sincerely thank all our co-authors and my mentors, funders of this work, and all participants, field workers, and researchers involved in the WaSH Benefits Bangladesh study. Thank you for listening. Please feel free to reach out if you'd like to discuss further, and I'm happy to take questions.
Thank you so much. I'm curious if you have any insight into what the actual WaSH interventions were, and like if that may have played a part in success, like, and the geographic area that they were.
Oh, you mean what constituted a WaSH? So
Yeah.
So here, so in this picture, for example, for the WaSH, so these are the different interventions they've deployed. So water treatment, like chlorinated water, putting up latrine upgrades, setting up potties, scoops, hand washing, and also for the nutrition, they gave out these nutrient supplement, lipid-based nutrient supplements for the nutrition. And in terms of geography, so this was done in 4 rural districts in Bangladesh. I don't know how to pronounce them, but and 4 rural districts in Bangladesh, like at the center, north central of Bangladesh.
Oh, thank you.
Thank you. Yes.
Thank you so much for your nice presentation. So this historical, I'm basically from in Bangladesh. So you have rightly addressed few issues and shared the related to the diseases as well. But do you have any comparison between the, like she said already, geographical location is a very complex in Bangladesh. So in different geographical location, we have different type of technological options for the improve sanitation and water purposes as well. But the key challenges is practice level of the hygiene. So do you have any implication of this study, the practice level of that beneficiary?
Yeah, so thank you for that question. Indeed, so it's one of the reflections I had, or we had as well with this study, is since we see that most of the transmission of Giardia is in the dry season, is it logical or reasonable to scale up during dry season? But actually, it's difficult since WaSH is mostly composed of setting up infrastructures. But I think this, the results here actually is kind of giving us hope in WaSH, because we see here that it consistently provided protection, whether it was in the monsoon or dry season. And in terms of hygiene, I think we need to, it's not part of WaSH, but I think it's behavior change is a part of it. So I think in addition to infrastructure, we need to educate more and promote more behavior change to more adherence to hygiene. And since this is an RCT, this was mostly, I would say, like an ideal scenario. So the adherence was really high. So, but in real world setting, I think.
Yes, because improved sanitation or water facilities is not only for the solution, because we have the solution, like more than 61% is still the improved sanitation in Bangladesh following the SDG letter. But in the rural context, we facing this challenge, use of these services, like if we provide the improved sanitation facilities like latrine or any kind of containment system, but challenge is the practice. Community are using following their standards. And water, if you said the chlorination water we are providing, but they are not following the WSP, water safety plan, water collection to consumption. So it's also the impacted with their health as well. So I think this study, it should be incorporated, not only the improved sanitation and water facilities, considering the other aspect as well, the behavioral science and the practice level and the availability of the services as well.
Yeah, I definitely agree with you with that. And I think in the other session before this, I heard what research we need more, or I think it's in the plenary, like we need more research about community effectiveness trial, where we assess the effect of an intervention as it is, as it's happening in real time, real conditions. Yeah, I think that would be very helpful. In addition to, of course, efficiency trials such as RCTs, such as this.
Okay, I think we're going to have to move on since we have another speaker in this session. If you had a question, you didn't get it asked before you moved out to speaker, follow up. Thank you. Okay, last speaker is going to tell us about the effects of extreme weather events on cholera in the Democratic Republic of Congo, 2020 to 2024, the WaSHmobile program. The speaker is Kelly Endres from Johns Hopkins University.
Great, thank you so much, and thank you to my other speakers as well. So it's really great to be here with you guys. I know it's the last presentation of the day, so thank you for bearing with us. My name is Kelly, I'm from Johns Hopkins, and today I'm going to be talking to you guys about some work that we've done on the effects of extreme weather events on cholera in the Democratic Republic of the Congo from 2020 to 2024, and then additionally looking at how we take these findings and use them to tailor climate-resilient WaSH messaging as part of our WaSHmobile program. So a few different things going on here, but I think it's not really a surprise to anyone in this room that the fact that climate change and severe weather events impact cholera and other diseases, that's pretty well documented at this point. We know that disruptions in weather patterns, so things like droughts, heavy rainfall, floods, landslides, and ambient temperature changes, these all affect water in different ways, as well as sanitation systems, which can increase the risk of cholera outbreaks. But despite these kind of clear links between climate events and cholera and other diseases, the evidence on health and WaSH behavior impacts, specifically in humanitarian contexts, remains limited, which is information that's really essential to guide climate-sensitive WaSH interventions as we go forward. So there's a few different parts for the background here, so bear with me, but data for this analysis comes from our WaSHmobile PITCHA7 program. So you may have heard at this conference before or in different publications that in the DRC we've been implementing the PITCHA7 program since 2020 to build evidence on rapid, targeted interventions that reduce cholera and diarrhea and improve WaSH behaviors. So We're kind of rebranding right now, so Pitch 7, we're now considering kind of the DRC-specific adaptation of our larger WaSHmobile program, which includes Pitch 7 and other studies that we've done in Bangladesh, and then things going forward into the future. So the target of WaSHmobile is that through mobile messaging, we can deliver timely, low-cost public health alerts without relying mainly on those resource-intensive in-person visits. So then the intervention we have here that I'm using data from is from our Pitch 7 program, where the program is initiated in a healthcare facility with delivery to patients with a hygiene kit, as well as quarterly home visits over the next year. And then finally, we have a mobile health program delivered where a doctor character at a local hospital named Dr. Pitcha sends weekly automated voice and text messages to diarrhea patients, patient households over that 12-month period. And then in the DRC, Pitch 7 also focuses on understanding cholera transmission pathways and designing these climate-resilient, scalable WaSH interventions. So the main part of our program that we've adapted for climate resilience is our mobile messaging, informed by the data that I'm looking at today. So here I show an example of what we call an interactive voice response message, or IVR message. And in this example, we meet two of the characters that we have for our program. So Dr. Pitcha at the Cholera Treatment Center, and then Mwanza, who's the mother of a young child who comes to the healthcare facility with diarrhea. And so participants can really interact with these messages. They are asked to help explain to Mwanza how to correctly boil their water. In this example, press 1 or 2, and then based on if their response is correct or incorrect, they receive feedback from Dr. Pitcha. So this is the first component of Pitch 7. So we did actually evaluate this trial with, this was randomized to participants were randomized to one of two arms and followed for 12 months to investigate WaSH behaviors and diarrhea disease outcomes. The first arm received that standard message that is often given in the DRC at health facilities on oral rehydration and a basic WaSH message. And then the Pitch 7 arm received those components I talked about, so the healthcare facility visit, quarterly home visits, and then our 12-month mobile health program. And so we did analyze this and publish it in Clinical Infectious Diseases this year, not 2020, that is a lie. In the randomized control trial of this component, we found that the WaSHmobile Pitch 7 program resulted in reduced healthcare facility visits for diarrhea, reduced diarrhea prevalence, reduced stunting in children under 5, and then also sustained improvements in WaSH behaviors throughout that 12-month period, which is really important. So then the other component of our Pitch 7 program is in 2018, we established a Pitch 7 enteric disease microbiology laboratory in Bukavu, which is in the eastern part of DRC in South Kivu province. And at this laboratory, we analyzed both water and stool samples by bacteria culture for Vibrio cholerae. And then we combine this with our cholera surveillance system, which is conducted in partnership with the DRC Ministry of Health, where we conduct cholera surveillance at 115 different healthcare facilities in South Kivu. And then we can use this surveillance data to track cholera cases over time and investigate this relationship between cases and climatic factors. So on the map, you see the red crosses are the health facilities, and then those gray dots are the diarrhea patients that we observed in part of the study. So through our ongoing surveillance, we were able to track cholera outbreaks across Bukavu. We have this data from March 2020 to March 2024 here for this analysis. On the slide, you can see that we observed cholera outbreaks in 2020 and then only sporadic cases over the next year. And then the next large outbreak began in 2023. Interesting for some background, this was about 14 months in 2023 after a large oral cholera vaccination campaign was delivered with over 1 million doses distributed in the area. So even though we know that the outbreak is attributed in part to some low coverage of this vaccination campaign, we were interested in investigating the role of climate variables in terms of driving the cholera outbreak, or the different cholera outbreaks in our context. So for our analysis, we focused mainly on rainfall. Here we have the average daily maximum precipitation by month over our study period. And you can really see we have a cyclical dry season, monsoon season here. I'm going to go a bit fast just for time. And then in addition to our average precipitation data, we calculated drought and wet periods using something called the Standardized Precipitation Index, or SPI. And this is a widely used indicator that quantifies the departure of precipitation from historical averages for a given location and time scale. So it essentially measures how much the observed precipitation deviates from the long-term mean expressed in standard deviations. So the more positive the SPI value, the wetter than average conditions are, and then, well, negative values indicate drier than average conditions. And this 3-month SPI that we use really provides a comparison of precipitation over that specific 3-month period with the precipitation totals from the same 3-month period for all years in the historical record that we used. So this is the SPI based on the precipitation data for our study location. So then I've added on the slide here the different categorizations that people use with SPI, from extreme wet all the way down to severe drought. And you can see we did not have any extreme drought during this time period. Okay, so because our time is already getting a bit limited, we'll focus on 2 key findings for our presentation. So first, we looked at our diarrhea patient surveillance data. So we were collecting diarrhea patient surveillance data and then analyzing these bacteria culture samples. And we found that based on the SPI data, cholera was higher during periods of drought as well as during periods of higher than average precipitation, so these severe wet periods. In addition, we looked at how different WaSH behaviors, this is really interesting, how different WaSH behaviors targeted during our program were impacted by precipitation and drought measured with SPI. So we found decreased hand washing with soap during droughts only in our control arm, but not in the Pitch 7 arm. And we were really interested to see this finding because it could show that part of our intervention is more climate resilient, where even though during periods of drought we're seeing decreases in hand washing in the control participants, this didn't occur in our intervention arm. So even though water availability for hand washing may be more limited during this time. Oh, and there's the, sorry, forgot about that. There's the ORs for that. So based on findings like the ones I just described, we can then go on to tailor our mobile messaging to address the impacts of climate on cholera and WaSH behaviors and increase the climate resilience of our interventions. So here specifically, I show an example message that targets our first finding. So using kind of like this simple, straightforward language, we can highlight risk during a specific period of time. So it's an actionable period of time for participants to take certain actions, like the hand washing and treating stored water. So we really highlight the high risk of cholera due to climate conditions and then highlight an important WaSH behavior. And then our second message that we exampled of tailoring like this is a voice message. This is a call that participants would receive, is to address our finding of the decreased hand washing with soap during droughts, specifically in the control arm. So even though we didn't see this in our intervention arm, we still thought it's important to maybe highlight this more to participants. So in this message, we address that it can be harder to find water for hand washing during dry periods. And then we remind participants that going to the healthcare facility with diarrhea is more costly, both with time and money, than collecting water for hand washing. So looking forward, we're really working on devising a system for our WaSHmobile program where we can connect findings on current and forecasted precipitation or other climate data, and then combine these with our messages and be able to really send these either as alerts or as reminders to different participants or different beneficiaries in high-risk areas. And so there's still a lot more different analysis we can do with our climate data and a lot of ways that we're looking to take this. So of course, to do an analysis like this, you have like a whole village of people that you need to thank at many different institutions, especially to my colleagues in the DRC, at the Catholic University of Bukavu, and of course our funders. And then this is our study team in the DRC, and then just for our final slide, we have a website that we launched yesterday for WaSHmobile, so please check that out. It's highlighting all the things we've done and all the things we're kind of thinking of doing in the future and how we're really looking to operationalize what we've done with different organizations. Yeah, so thank you so much.
Okay, we have some time for questions. And you're the last presentation in the session. I guess if we ran over
Okay, well,
a couple, 3 minutes.
lots of
it would- it
questions.
might be-
Yeah, of course.
Do the I guess participants in a study is a little bit different than if you were to implement this without the study backing it. But is there some sort of compensation? Is it free on a phone? Because I feel like a lot of these people might not have the capacity to text and call and.
So this intervention specifically, obviously, we were covering the cost of the messages, but really the goal going forward is to have this be a system that's set up during a high-risk period. So there's an outbreak going on, and then we can send messages that are specific to things that are happening, and so that would either be taken over by like an implementing organization, or ideally, like the local governments could take this on, and so that's why we have our website, where we're really looking to like take what we have and operationalize that. Because there is a cost of the messages. It's really low though. It's like cents per message. I mean, we have the exact numbers. I don't know off the top of my head, but yeah. Good question. Yeah, please.
Thanks for a really, really interesting presentation. Thinking about areas with low cell phone coverage, mobile phone coverage, is this work based on kind of foundations of literature, of messages that could be put out through radio or other types of sort of communication strategies separate from a phone app, or was this work really based on the phone messages?
Yeah, so we're really specifically focusing on mobile messages with our WaSHmobile intervention, but certainly there's a huge field right now of trying to forecast different things, even like landslides, and I mean, people do it now with hurricanes, obviously. So no, we're specifically looking more at mobile messaging, but in terms of coverage, like this was in a pretty conflict-heavy part of DRC, and we found that almost in most places there's decently high mobile coverage, like at least one sort of phone in the household that can receive messages. We haven't done as much in rural areas, but even then you could have, if you're tapping into existing community health worker infrastructure, or radio, or there's a lot of ways you could go with that. So,
I just wondered about mobile phone ownership and who has power over that phone in the household, and whether that influenced if the messages got through.
Yeah, so we've actually have looked at that. I think we had a colleague who's actually we presented last year on a process evaluation from part of this intervention. One of our colleagues in DRC led that analysis. And so we actually found that while specific ownership was more often male, I think we found that women really had access to the phones even more than men. And so we were looking at who were reading our messages, and we saw more women reporting having read and interacted with the messages than men, actually.
Okay, if no further questions, thank you very much. And I'd like to thank all of the speakers, as well as the audience, for this session. And we appreciate your participation.
How'd it go? Thanks.
Is it something? It seems like it might be a Wi-Fi issue.
I think I need to just work on it.
Go.
Kelsey, hey. And then today. What's happening today?
Directly no, but
That's by Evan Thomas.
Anna.
I work with Carl on a different one.
Oh, I was in there. Yeah. Yeah.
He was only here one day, and I think I missed him if it was yesterday. He's here already. He's a Duke 3A. He's a busy guy. Yeah, thank you.
I wanted to ask you, I want to send you. So, AI thing.
Thank you so much.
It was good? Okay, yeah, okay. It went smooth.
It's like, oh, I just really feel like I
I gotta get the recording,
With all the math.
but yeah, she
So I've just been twiddling my thumbs. There's like a few sections.
What'd you think of these guys?
They're okay.
You know, that was,
I got a
You know.
7-minute recording.
I kept trying to like not look at the camera.
and I can say that was not one of my best presentations.
Yeah, remember I told you I damaged my hearing.
IEEE I thought was better. I thought I did better with IEEE.
It's like the name of the hearing. Sounds like I'm saying psychology. No, not psychology. Yeah, the one that's right.
Just don't drink it. You'll be all right. We're scaring you out the water.
I can't hear anything. And the funny thing is,
If you want to use my computer for the day, for this afternoon or tomorrow or whenever, and get the figures you need, all of the performance reports are here. So this is the most updated, best regression of. This is on the GitHub. But you get it from.
I don't think you need to vote on anything.
I mean, if you like enough the way the figures look, I feel like it's fine. This is, yes. This is, okay, so this is split between train and holdout. Okay, so this is, what about test? I think the test data just isn't included on here. Split, holdout, train. Okay, well, why don't we look at these and write down any questions we have for Matt, and then we can talk to him about it on Friday.
Yeah, I met her this morning. I can't remember her name now. Yeah.
Shit.
Kind of crazy.
Just
Yeah, I think we mainly.
Just really could have.
Everything else is there.
It's not, but like most like
95% of it is there. You exclude